doing, particularly just with VIA, one thing that you need to appreciate is the fact that when you screen 46 HIV positive women, what you normally do is you prevent one death. So you see the importance of screening. Next. Next slide. So when we are coming up with a cervical cancer screening program, it rides on 6 essential components. Otherwise, if you do not have these 6 essential components, you are going to find that the cervical cancer screening program is not going to be successful. Reason being is that we know the success largely depends on the participation of the target population, also the quality of the screening test, and the effectiveness of the treatment of the lesions which are supposed to be identified during the screening. So what are these 6 essential components? The first one is service delivery. We shall go into explaining what this means. The second one, health workforce, in which you are involved. Then there is information, then medical products, vaccination, health financing, leadership, and governance. Don't think this is just at the national level. And with you, you are going to say, well, I'm not involved. No, 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 no. You are involved. And what is the ultimate thing that we want to get out of those 6 components? We want to ensure that we shall have very good coverage. At the same time, we are going to have improved healthcare, and the response is going to be very, very good. Next slide. So when you look ultimately at the program parts, what is it that we do in the first place? First of all, when we are setting up that clinic, first we need to identify the screening population. And you understand the screening population. You are going to talk about saying we shall be screening those who are HIV positive. We shall screening as well as those who are HIV negative. And you also talk about the age of the screening. The second thing that you do is demand creation. What do we mean by demand creation? You do not want to bring a service and people are not going to be using the service. What good is it going to be? Let's put an example. Here is an area where there are no women and they do not, maybe they are below the age of screening. It means there is no demand creation in that area. Then the next thing that we do is to screen and triage. If you remember a month ago, we were talking about the forms of screening which we are supposed to be using. Essentially, they can be the screen, triage, and treat, or where there is screen and treat. But when we want to focus on the essential components, especially where we are trying to talk about the elimination of cervical cancer, we want to talk about the screen, triage, and treat. Then we come up with a diagnosis. So depending on what you normally say, is this lesion less than 75%? Is this lesion more than 75%? Is it going into the os? During that time, then you are going to offer appropriate treatment. And of course, we need to have monitoring and evaluation. When you try to focus on these program parts, coupled with the 6 essential components, you are going to find that your cervical cancer screening program is then going to be a success. So let's start now teasing out. Next slide. We start with service delivery. Next slide, please. So The most important thing is service delivery. In service delivery, there are three important components: information, communication; second, screening; third, diagnosis. So in diagnostic and treatment services, you need to realize that this should not be separated from screening, meaning that you do not just want to screen a woman and you don't treat. Because when you find there is this woman who has got an acetoid lesion and it requires ablative method, what are you going to do? You are going to treat. Even in a situation where you can't treat, what you are going to do is you are going to refer this woman. Then, when you are doing screening, you have to take note that this should not affect other important health services, meaning that if you, who is the provider, is also involved in theater, we do not want to say theater is going now to suffer. There is this woman who is supposed to go to theater. You have to come to cervical cancer screening. If that's what is going to be happening, then it will mean that these other services are going to be affected. So we want somebody who is going to be there to be relied upon, saying that when there is need for this person to come for screening, of course, she is going to be there and she's going to offer the service. Next thing is that we do not want to separate the cervical cancer screening to be just somewhere else. The service, essentially, if you have put it probably in the OPD, you are going to find that a lot of women are going to be accessing this. And more importantly, you need to integrate this cervical cancer screening in other services so that you improve their health. If you see what has been happening is that your cohort, most of the patients that you get are the ones who come to seek for HIV/AIDS services. Probably before they go for refill, they pass through the department and then you screen. So this is one of the important things which you need to talk about: service delivery. Next slide. So if you look at service delivery, what do we want? We want every woman should be eligible to be screened and they need to access maximum service. When we are talking about service delivery, we want that service to be acceptable to a woman, and every woman should afford it and she should access it. And this is the thing that we need to integrate in the National Cancer Control Strategic Plan. It means that then this service delivery is up to max. Next. So we go to another one. All of you who are there, you are leaders, you are managers. We do not want you to be saying, well, when it comes to cervical cancer, and we are talking about leadership and governance, we shall just restrict it to those who are at the provincial levels or who are at the ministry. No. So what do we do as who are involved? So the first thing that we need to understand is that Ministry of Health provides decision-making authority and resources, and it is there to direct planning, implementation, monitoring, and evaluation. But as far as you are concerned, as long as you are in leadership and there is this cervical cancer screening, you are supposed to create a unit of purpose. What we want is, we understand that what we ultimately want is to screen our women. And the second thing, because of being managers, you are supposed to be involved at all phases. And remember, you need to own this program. Do not start saying that this program of cervical cancer screening belongs to the ministry. Hold it firmly with both of your hands, because this is your program. And because you are managers, what you require where you are, try to build the team and make sure that a lot of women who are health providers are going to participate. Next. So we have teased out two pillars. We go to health financing. There should be a political will so that this program becomes a success. What we mean is that Ministry of Health hasn't just left it to external support. No. If the external support pulls out, it means this is going to crumble. That's the more reason why we normally say that Ministry of Health has built strategies so that those strategies, they yield results. And it's through intersectoral strategy. And we only involve the partners. And the other thing is that this requires adequate financial resources. And apart from that, you know what? You are going to be testing this woman. But remember, the test costs have got a cost attached to that. Diagnosis has got a cost attached to that, even treatment. So when we are coming up with this, what normally happens is that we have to look at how funding is going to be. We do not, again, want to have a barrier in as far as referring the patients is concerned. So this shows that, for sure, there is an element of proper health financing. Next slide. Next slide. The other thing is medical products, vaccination, and technologies. So when you are talking about another pillar, it is vaccination. Remember what we talked about in the previous didactics. When you talk about vaccination, you are going to see to it that this is one of the important components in as far as eliminating of cervical cancer is concerned. And those of you who have been in Lusaka, probably you have seen, again, artificial intelligence, where you have to use the camera, and sometimes where you have been having problems, because this is Android. There are thousands of pictures which have been loaded on that phone. Immediately, you use that phone the way you have been using the camera. It is going to tell you that this is VIA positive or this is VIA negative. So we even think through that. So this is one of the pillars. Next pillar is information. So information is one of the important things. The women should be made aware of cervical cancer, and they need to be educated and to be communicated to. How do we do this? We do this through TV, we do this through printed materials, and more important, when we find that there is this woman who has been diagnosed with a problem, they need to be linked to another level. Next. Health workforce. All of you who are there, by the time that we are starting the program, we have to identify who is going to be in the program. What are they going to be doing? How should we train? And we want you who are going to be looking after these clients to have good interpersonal relationships. To tell you the truth, if you do not have good interpersonal relationships, a lot of people are going to be shunning the cervical cancer screening. They'll be saying, the sister who works in that clinic, I think she doesn't have a good heart. For me, I do not want to go for screening. Or the sister who works in that screening talks a lot to people saying, This is what she has been seeing. So if you lack that good interpersonal relationship, you are going to find that your cervical cancer screening program is not going to be successful. And there is need for you to be dedicated when it comes to duty. If you are going to be coming, say, on Monday, you are screening, the other Monday you don't screen, people are going to say, well, even if we go to this screening clinic, we do not find the sister we're supposed to be screening. And that becomes a problem. It means the success is not going to be there. And remember, all of you who are on this platform, you have been trained in VIA. And I believe all of you have been oriented in HPV. Remember, we said HPV DNA testing is now the primary testing tool that we have adopted as a country. And both are competence-based training. We understand the levels that you have reached. But when it comes to screening, screening is divided into two. We have got population-based screening and opportunistic screening. Let's start with population-based screening. What is this population-based screening? Population-based screening is supposed to have a target group. What do we mean by a target group? So you are going to say that, well, the people that we are going to be screening, probably they are going to be the HIV positive or the HIV negative, and we need to have the age group. We are going to say we shall be screening from 25 years to 59 years. And apart from that, there is need for you to adhere to the protocols or the policies, and there should be a way of monitoring and evaluation of the program. And if you look at population-based screening, it is also referred to as an organized screening. Reason being is that it has got a pathway which is well planned and coordinated, and they make sure that there is proper monitoring in as far as that is concerned. Next slide. Hello?
Sorry, Dr. Kamfwa. It looks like we're having a few technical glitches at headquarters. Just give me 1 second.
Thank you so much. By the time probably they are getting back to that, remember, okay. So we were talking about the difference between the population-based screening and the opportunistic screening. And we have just outlined what it means about population-based screening, where we said that this is well organized, there is a target population. At the same time, we have even discussed that it is well coordinated, there is an element of adhering to policy, and there is monitoring and evaluation, and the coverage is essentially big if you look at population-based screening. Move the slides, move the slides. Move the slides. So, how about when we talk about opportunistic screening? So opportunistic is the one which is called voluntary, or sometimes we refer to it as spontaneous screening. So if you look at it, by virtue of being spontaneous, it doesn't have that effort to reach a particular population as compared to what we were saying in as far as population-based screening is concerned. And when we look at opportunistic, here it is performed at the sole initiative of you, who is the provider, and this woman who has come to be screened. And many women who are even screened in opportunistic screening, they are not in the appropriate age group. Next. So if you look at the opportunistic screening, you can have a woman who is 25 years, who is 20 years old. They can come, even if they are not showing any signs of precancer, or they do not have, as long as it's just at the mercy of you, the screening, and the one who wants to be screened. But remember, when we were talking about population-based screening, we were saying there is a target age group. Opportunistic doesn't have a target age group. Population-based screening, it has got a wider coverage. Opportunistic doesn't have a wider coverage. When it comes to evaluation, but population next slide. So the poor performance of a cervical cancer prevention program is essentially because there is poor planning, there is poor implementation, and there is lack of system for monitoring and evaluation. We know all of you who have joined us on this call, your clinics are a success. Reason being is that you have already made it a point that there is good planning and you execute the activities properly, and you ensure that every time there is monitoring and evaluation. No wonder we even have the quality assurance, the QA/QI people that have been provided by CDC. This is to ensure that the program becomes a success. Thank you so much. Next slide.
Thank you so much.
Thank you, Shakira.
Thank you, Dr. Kamfwa. I really appreciate it. As always, a very insightful lecture. We're going to go ahead and move to our post-test. And I do see that we had a hand up, and I'll get to your hand. And if anyone has any follow-up questions, don't worry. We will have a section where you're able to ask your questions and get the right answers. But we're going to go ahead and move into our 3 questions so that we can get our answers. Chusi, if you can please go back to the 3 questions at the beginning. Which one? Okay, thank you. So question number 1, which one of the following is a characteristic of opportunistic screening programs? A, it has a defined target population. B, it has effective recruitment strategies to achieve high coverage. C, it is a healthcare system with the capacity to screen, follow up on those screened positive, and provide treatment as indicated. Or D, it lacks quality assurance systems. The poll is open, so you can go ahead and register your response. Okay, so 17% said that A was the correct answer. 17% said that B was the correct answer. 17% said that C was the correct answer, and 50% said that D was the correct answer. Dr. Kamfwa, any insights into what is the correct answer here?
Thank you so much, Shakira, and thank you so much, listeners. All of you have joined us on the call. For sure, the 50% have got it. It lacks quality assurance system. So if you find that there is a target population, it is population-based. Strategies to achieve high coverage, it is a population-based. So when there is lack of quality assurance, it becomes opportunistic.
Thank you so much. We'll move on to question 2. Which statement is correct regarding a population-based screening program? A, it has a higher coverage rate. B, it has lower efficiency in terms of the number of cancers prevented. C, it has no management team responsible for planning and implementation. Or D, it is also known as voluntary screening. And the poll is ready for your answers. Mm-hmm. 95% said that A was the correct answer. 0 selected B, 0 selected C, and 5% selected D. Dr. Kamfwa, please help us understand this question.
Thank you so much, you the 95%. So when we are talking about population-based screening, it has got a higher coverage rate, not opportunistic. Thank you. Those who chose D, remember the voluntary is opportunistic. So the answer, of course, it was the 95. It has a higher coverage rate. Thank you so much.
Thank you. Now we'll move to question 3. All of the following are essential components of a successful cervical cancer screening program, except A, service delivery, B, financing, C, health workforce, or D, smoking. Okay, and 100% said that D, smoking, was the correct answer. Dr. Kamfwa, please.
Thank you so much, the 100%. Even when you are leaving this call, please remember the 6 components: service delivery, health financing, health workforce, information, leadership, and governance. Even when we meet, please remember these 6 components. It's part of you, and it's part of what makes a successful cervical cancer screening program. Thank you.
Thank you so much. Now we are going to move into our case studies, and we're pulling up the first one. And don't worry, for everyone who has a question or who had their hand raised, we haven't forgotten you. We just want to get through the case studies first and then give people an opportunity to ask their questions to our panel of experts. Okay. I believe I shall share the case studies or, oh, okay, thank you. So, Petauke, Dr. Frank, please grace us with your presence, and we're looking forward to hearing your case.
Thank you so much. This is Dr. Kapent from Petauke District Hospital. Are you hearing me?
Yes, we are.
Okay, thank you so much. Good afternoon, team and the colleagues. I am going to present this case presentation that we had last week. This is a female 38 years old, G4 para 3. She came to our hospital with a history of PV bleeding, general body weakness, dizziness, and we discovered that the gravity index it was positive. On a past medical history, we discovered that she was a non-RVD patient on CAT since 2019. So she was diagnosed as an incomplete abortion that was confirmed by scan, and then she was treated for the same. So later on collateral history, that was on day 5. So we discovered that the patient has history of having repeated episodes of PV bleeding. That was it was in 2020, which she was admitted at St. Francis for the same bleeding. And then at once they did a cervical biopsy, which was taken at that particular time. So the time we were about to discharge the patient, we discovered that the results they were not available. And then we made the decision to send the patient to cervical cancer screening. So on the examination of the patient, we discovered that the patient, she was weak, unstable, and the pallor was 3+. The pulse of that patient was 115. And then on the vaginal examination, we discovered that the patient has some PV bleeding. The os was open, and we saw some clot. Another system, they were in a normal range. Next slide. So from the ward, we sent the patient to cervical cancer screening. We discovered that at the time we are examining the patient that the cervix wasn't well appreciated. And then the time we are examining on speculum, she had some bleeding on contact. So we came up with a diagnosis with query intracellular carcinoma in situ. So later on, we discovered that she had some result. She came up with the result, which was collected from St. Francis, which shows as she had invasive, moderately differentiated keratinizing squamous cell carcinoma. So if we go through in our history, we say the patient was in a general condition, she was pallor 3+. So she had HB2, and the red blood cell was 1.6, and the platelet, they were in the normal range. Next slide. So from that time, the time we have been together with the patient, we managed to treat the patient accordingly. So we boost up some blood, and then we discharged the patient with HB 11.1. And for the patient was discharged, she's out of danger, and we write a referral to UTH, which was supposed to come this week. So we missed up to take her this week. We are sending her next week. And then from now, we as a team here, we are trying to say, we came up with some questions where we can throw through the team to say what else would be the differential diagnosis and how best would we have managed to this patient, and maybe to go through the follow-up to this patient. Thank you so much for this short presentation.
Thank you so much for that great case presentation. So we have some questions here listed on the slides, and we do have Professor Mulindi Mwanahamuntu, Dr. Fradekunga, are you on the line? And Dr. Francis Mubanga. We're looking for your expert opinion about this case. And if anyone has any questions about the case as well, or need anything made more clear, please raise your hand so we can do that. Professor Mulindi, please go ahead.
case are you? Is that patient from Katete? Are you in Katete, doctor?
I believe they're in Petauke, sir.
Okay, they're in
Mm.
Petauke.
Mm.
Yeah, that is a very interesting case. The first time that she came with a pulse of 115 and HB of 1.3, that was a dangerously low HB case. In fact, she was in shock. You have done a good job to reverse the shock and up the HB to 11 grams. My question is, how many units did you give for that? And what is the period of time in between the HB of 1.3 and the HB of 11? How many units did it take you and how long before we go into the nitty-gritty, just to clear? Oh, the presenter has gone?
No, he's still there, Dr. Kapinde.
Yes, I'm listening. Thank you so much, Doc. Just for point of correction, the HB was a 2.9, not 1. That was the red blood cells, which was 9.6. So we managed to give a 6 unit. In fact, we kept the patient for more than 2 weeks. So we're together with the patient and we are monitoring the patient on a daily basis until we managed to reach that HB up to 11. The scan and the chest X-ray, we did it. They were in a normal condition. They were normal. Thank you so much.
Thank you very much. Now, your first diagnosis, which you said at the point of examination, you said that you saw a cancer in situ. You diagnosed as a cancer in situ. How did you make that diagnosis of cancer in situ?
Thank you so much, Doc. So after treating the patient as an incomplete abortion, and we send back the patient to cervical screening, I don't know if you go through our slide, we said a query. It was a query. It wasn't a confirmation because we were together with the patient in our ward.
Okay. I think I agree with you, but the first time you did a speculum, if you do a thorough speculum, you should be able to describe the cervix in a better way than just saying that cervix is not appreciated, because that doesn't mean much. We would like to have wanted to know what you found on the cervix that led you to think that there was cancer in situ. So it is a bit, it's incumbent on doctors to try very hard to describe what you see on the cervix, the lesion. How big is the lesion? Where is it located? Is it just on the cervix or does it spill onto the vagina? Is it covering the whole cervix or is it felt in the parametrium? So that you give us a bit of indication. My judgment is that because she was pregnant, it probably isn't very advanced cancer of the cervix. Do you know anything about staging of the cervix, doctor? What would you say that this patient you are referring to UTH, what do you think is the probable stage of the cancer?
Thank you so much, Doc. We have noted, and then the time we wrote the referral letter, we classified that patient on the stage 2, clinical.
Okay. Okay. How did you evacuate the uterus?
So for that one, what we did, we didn't did the MVA. We used misoprostol. That was 600 microgram. So we gave patient sublingually, and in a few hours, the patient has evacuated. She's expelled the RPOCs.
Brilliant, because that is what is known as medical evacuation of the uterus, as opposed to putting instrumentation on the cervix that can provoke bleeding. What was going in my mind is that how did you drop the HB to 2? Could it be that you were poking and trying to evacuate the uterus in the presence of cancer? So that now answers the question, and it allays fears that a correct mode of management was done, which is a medical evacuation of the uterus. Does anyone have any question? Any more question to clarify, to see what was done correctly and what may not have been done? Any questions?
Yes, I did see that Mr. Humphrey Mutale, he had his hand up. I'm not sure if he wanted to say anything. But
no,
I do
it has
see-
been
Go ahead.
clarified by the doc. Thank you.
Okay, thank you, Mr. Humphrey. And then Mr. Freddie Chanda, please go ahead. You have the floor.
Thank you very much. It's a very interesting case from Petauke, and well presented by the Eastern Province team. And thank you, Prof, for your clarification and comment. So I'm just thinking to say, this patient was first seen in Katete, St. Francis. That was a year before the patient went to Petauke. So I'm just thinking to say, that time when the biopsy was done in Petauke, so if a system was up to date, I'm thinking to say, maybe would have prevented this case from reaching this far. So I'm just thinking, so how can we fix our system? Because I believe even today is the same. When you do a biopsy today, you may not get your results maybe in a month or so, or you may get in after 3 or 4 months. So I'm just thinking around that. Over to you, Prof. Thank you.
Yeah, thank you very much. I missed the timeline because I think I had an interference in the course. There is a time lag between the first biopsy, and when was the first biopsy done? Before pregnancy or after pregnancy?
Thank you, Doc. The first biopsy was done, that was in 2020, and that time the patient wasn't pregnant. So the patient came to us, that was in 2021, and the biopsy was done at St. Francis, that was in 2020.
What did the biopsy say?
So the biopsy mentioned about the invasive, moderately differentiated keratinizing squamous cell carcinoma.
Oh, I see. So thank you, the previous doctor, for noting that. I think the system kind of failed the woman, because 2020 and 2021 is a long time.
Sorry, Professor, is it okay if you could move closer to the mic? We can hardly hear you.
Can you hear me now?
Better.
Okay, so I'm just saying that 2020 and 2021 is a long time. So the patient was lost to follow up after the initial biopsy. The patient was lost to follow up. I know that Katete does their own histologies. That's why I wanted to be sure where the patient is, because St. Francis is in Katete. So the biopsy was received, and what happened? Why was the patient lost to follow up? Are there
Professor,
any patients that you have results and you have not seen them? You have not talked to people for whom you have the results?
So, Prof,
Mhm.
yeah, maybe this is good time. So, yes, Katete for some time had been having links outside the country where they were doing their histology. However, for a year plus now, they're no longer doing that. So we are relying on either private or UTH. And we've been having such a lapse in time from the time that the samples have been sent to UTH and the time that we receive results. We have worked on something that, just like what Fred is saying, we've been having this as a hindrance to offer appropriate quality care to our women. So this, I think we are almost walking past it. We have established links through the UTH, and we have been located specific pathologists who we are going to be in touch with, and some lab team, and we're hoping this is going to improve. Perhaps if we get delayed, maybe it could be 2 weeks or so. We did receive a few results some week ago, and we are hoping that we could receive some again. Are there any results that could not have been communicated to some clients? I think sometimes we are having these delays even when results come, and we saw that this could have been a typical case where there could have been some miscommunication by the person that saw this client first when the results were available. They could have not communicated the appropriate results and let go of the woman without help until she landed at Petauke District Hospital with a complication, which was an abortion, and that's when she was attended to. So we are trying to fix that issue of delay in communication of results and intervening, referring to the appropriate person to take care of that woman. Over.
Okay. So I think, Madam Moderator,
Yes, sir.
for the benefit of our colleagues, let me say the consequence of delaying patients' diagnosis and treatment. Let me put it very clear to you so that we all understand the consequences of these delays. First of all, if this patient was found to be 1A, meaning that the cancer of the cervix is the cancer was limited onto the cervix by microscopy, it meant that any surgery done on her, she can live up to 95%, she will live more than 5 years. Now, when we delay and present the woman at the point of stage 1B, which is microscopic, and we can see it because of lymph node involvement and so on, the chances of living for 5 years drops somewhere to about 85%. When we come to stage 2, which now you are thinking is stage 2, again, I do not know, but if she is in pain, it is probably stage 2B. And if she's still not yet much in pain, it is probably stage 2A. But anyhow, both of these stages, you drop the survival rate, the 5-year survival of the patient to somewhere around 80% in a very, very good center where she will receive very good irradiation therapy. Otherwise, it can be as low as 70% chances of living to the age of 5 years from the time of diagnosis. So you can see that the delays are directly linked to survival of the patient. They are also further linked to complexity of treatment. the complexity of treatment. What we want as surgeons and also as people who treat cancer is to choose one best way of treating the patient, either surgical or irradiation therapy. Now, most of these cases that end up with a delay, on the table we do find lymph node involvement, which means that we invariably give them two forms of treatment which will require us to go into adjuvant irradiation after doing surgery, meaning that we have given the patient two forms of treatment, which is very deleterious on the body of the patient. So I think this afternoon, that's all I wanted to talk about, the consequences of our delays. We must synthesize this within our minds and know the consequences of delaying a patient. But we also have learned here that the development or the progression of people who have HIV, of a long-standing HIV, is very, 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 very quick. As you are waiting to send the patient to Lusaka, please can you do investigations that pertain to her immune system? Okay, compliance with the HIV drugs, and also basically her immune system, boosting up her HB and the general conditions so that we can offer her treatment when she comes to Lusaka. Thank you very much.
Thank you so much, Professor Mulindi. I mean, honestly, you have said it all. We cannot delay. We cannot allow women to die due to these delays. Dr. Kamfwa, I see that you also have something that you would like to add. Please, go ahead.
Just a quick one. No wonder if you look at our lecture at the outset, it was talking about 6 essential components of a successful cervical cancer screening program. And when we looked about that, we had to talk about the importance of linkages and referrals. Remember, if there is proper linkage of this woman from one level to the other, or there is even proper referral, you are going to find that our women are not going to suffer. So for us to ensure that, we need to adhere to the tenets of the 6 successful components. And again, when you look at the same one where we are talking about population-based screening and opportunistic screening, when we talked about population-based screening, we had to highlight the importance of referral and linkages. That's why at the outset of this lecture, we wanted to bring that to your attention. Thank you.
Thank you so much. We're going to take a look to see what Chasefu is doing. Can we please have Chanda Musonda come forward? We're looking forward for your case presentation. Chanda, go ahead.
Good afternoon, everyone. This is Chanda Musonda from Chasefu District, Kanyanga Mission Zone Health Center. So our case study for today, can everybody hear me? Am I
Yes,
clear?
Yes, we can get,
we can
hear
hear
you, Chanda.
Okay, thank you so much. So, Violet Makwakwa, female, like 47 years old, was diagnosed with HIV on the 15th of March 2017 and initiated on the same day on TOE in Chasefu District, Lunzi Health Post. Then The client has actively been on ACT since then and has been keeping appointments. She had her latest, She had her latest cervical cancer screening in August 2021, which indicated query cervical cancer, and she was referred to Lundazi for cryotherapy with possible LEAP. And later on, feedback gotten from Lundazi was patient had cervicitis, which was treated and to be reviewed after 2 weeks. Then past medical history, patient was diagnosed with TB in 2016. Then on the time we were doing history taking, in 2017, the patient was screened and diagnosed with query cervical cancer. And in 2021, it was the same diagnosis, but she's been treated as cervicitis respectively. And family history, no history of cancer-related conditions in the family. Social history, she's married with 3 children. Husband is currently on ACT. And does not drink nor smoke. So physical examination on the 25th of August 2021, BP was 102/60, House 93, 93 beats per minute, temperature 36 degrees Celsius, height 154 centimeters, and weight 40 kg. Next slide, please. Then the table we're seeing here, the date, since her viral loads without the date collected, it was on the 15th. This is the date which was initiated on the drug, 15th March 2007. Regimen, she's on TOE. Then currently she's on TOD. Next slide. So our questions, question 1, how best would we have managed this patient? How best would we have managed this patient? Been treated for cervicitis on 2 occasions prior to the 3rd screening. Question 2, how can we help the client with suspected cancer who needs urgent histopathology, who do not have money to do express lab tests?
Okay, thank you so much for that case presentation. Now we're going to move to our panel of experts. And if you have any questions, please raise your hand, or any clarifications needed, please let us know. Okay, is it Dr. Kawunga? I see you.
Yes,
Yes, please go ahead.
for Prof. Kams. I know that possibly we don't have peaks which we can really compare. I had a look at this posting. It's confusing not to see what was confusing about the pictures. I know that's why we emphasize that after when you suspect infection, you treat, and then they come back for appropriate rescreening and plus minus treatment. So in the absence of these pictures, I think it's very difficult. But overall, I think we are seeing a number of these cases, not only in Josephus, possibly countrywide at UTH. Of late, we were discussing with Prof. The team over these cases who have been recently, actually, most of them checking up negative, and subsequently in 2-3 years, they have quite advanced, reaching even 3B. So I think overall, we have to really, the teams in these centers, I think, shouldn't really relent. They should have a very high index of suspicion on these women, especially the HIV positive women who are at risk of quite progressive disease. So this was just, of course, a missed case of one of those women we are now having, who have been attending our screening system, but they have been missed. And the best really management possible is to have a high suspicion of index of suspicion, and the consultation, of course. What is going on, I think, is very important currently, where there's tele consultations on the peaks. I hope that this will change the game plan. And then because of the missing peaks, it gets on not to give appropriate answer. But high index of suspicion is key, and the consultation. Then histology processes, I'm sure we have heard similarly. Our patients, that lag, that time behind, we are behind, I think, almost always as a system. We have, in many times, we have really disappointed our clients because of this lag in histopathology processing. So that's what really, my concern also was on when they queried the ICC, and then cryotherapy was thought of, and a leap. That's also a concern. I'm sure that diagnosis was made at the center, but I think it was overturned at the referral receiving facility. So otherwise,
Hello?
the primary had it on point. Are you getting me?
Yes, you broke up for just a little bit.
Yes.
So I don't know if everyone heard everything, but yeah, please continue.
I was saying the primary center, which saw the clients, had it on point by suspecting ICC, and unfortunately it was turned down at the receiving facility. So I think there should be harmonization of really of consultations and the deliberation on our cases we see. Thank you so much.
Thank you so much for that, Professor Konga. We really do appreciate your insights.
I'm not professor.
Sorry?
I'm not professor.
So you're Dr. Konga?
Yeah.
Okay. But thank you for that correction as well. I see Jane Matambo. You have your hand up. Please go ahead.
Yes, I just wanted to ask if the facility is able to take pictures, because that would be very, I mean, it would have been a better discussion. It's a good discussion, but it would have been better discussion with pictures, because we actually use those for quality improvement, so we can compare A and B. But also, I don't want to go through what Dr. Kaunga said, because I totally agree with everything that he has said. Having a high index of suspicion a need for pictures. Yeah, but I also want to commend the site because they've been referring this woman. 2017, they suspected invasive cervical cancer. 2019, they suspected the same. 2021, the same. So this should have raised antennas for the site that was receiving these clients, because this client has been consistently being referred. So other than dismissing, not necessarily dismissing, but just treating it for cervicitis, they could have probably investigated a little bit more the fact that from the referring site, they've been referring this woman from 2017 for a suspicious lesion. So that's my contribution. And also, if it's possible to send in a picture for the times that this woman has been referred to the referral site. So if they have a picture, they can send it to the doctor who is at the lip clinic. It would have been probably a lot helpful as well. Thank you.
And sorry, Jen, if she has, she can send us, please, those 3 pictures which she has been doing.
Exactly.
Yes.
Exactly.
Thank you, Dr. Jane. I see that Chanda, do you have your hand up to respond to Jane? Or should I go to Dr. Kamfwa? Okay, please go ahead.
I have a hand up, please.
Go ahead, please.
Yes. So I think there was a mistake. In 2016, it was diagnosed as cervicitis. And that was in Lundazi, the time they were doing the mobile cervical cancer screening programs. Then the second one, it was also from Lundazi. That was, we got that history from her because the time she came for the screening here in Lunzi, that was the 3rd time. That's when we diagnosed as query ICC. So the first 2 were cervicitis, and she was treated as cervicitis. That's when we had to refer her to Lundazi, the 3rd time she came. So the pictures there, the 2 previous pictures, it's not from us. Kanyanga is from Lundazi, and we don't have them. But the 3rd one, I think we have it. Let me just try and send it. Let me check.
Okay. Thank you so much. Dr. Kamfwa, please, your insights.
Yes, again, Shakir, when we were looking at the lecture, we talked about health financing as an essential component. And in the health financing, we talked about funding for diagnosis and for treatment. So meaning that even for the patient who does not have money for histopathology, there is a way that we are supposed to cater for that patient. Let me first come to the CDC supported provinces. I hope even maybe Dr. Omega is here, but Goodson is supposed to maybe give a comment. When you look at Southern Province, what they have done is they have apportioned some money specifically for referral of the specimens to Livingstone, because in Livingstone, there is a hub which CDC has been using to support the pathologists. That's what they have done. So every patient, even if they do not have money, as long as a biopsy has been taken, this biopsy reaches Livingstone. But even us as ministry, if there is a way of a biopsy reaching Lusaka, the patient does not have to pay. Then I believe, because Eastern Province is also a CDC supported province, it could be that there is also a budget line that Goodson and let me say COAG has put in place of how the biopsies are supposed to reach. Goodson, maybe your comment, because I know what is happening in Southern Province with regard to the biopsies.
Thank you, Dr. Kamfwa, for that feedback. So we do, yes, have that support. And like I mentioned earlier, we have worked that out, and we are hoping that from now onward, we will be able to see results come early. What we observed the past few months or past year is that it was more like a decision by the providers themselves, where they got a little bit frustrated that the results when samples are sent to UTH were not coming in time. So they were being troubled by the owners of the specimen, the client, that they could not get the results. So that frustrated them, and they started like keeping the samples until someone has money for a private institution. However, we have discouraged against that, and that prompted us to do that. Going further, we are working on establishing a histopathology lab here in Eastern Province, and this will really help. So I think that's something that we have worked past, and we are hoping we'll sustain the good practices that we have started over.
Thank you so much for those insights and for that information. So Eastern Province, actually, I think this is from Giza, who's in Lusaka. She made a comment. We have a problem with women who are diagnosed with cervical cancer, but still coming back to our facilities for help while they are already in CDH. They are just given appointments from UTH. So that was in the comment section, just to make sure that we got everyone in the comment section. And then Professor Mulindi has said, thanks for answering the second question, Dr. Kamfwa. So if there are no more, Chanda, your hand is up. Do you have anything else you'd like to say about this case before we move to the next one?
I think she didn't drop her hand from the first time that she raised it. Okay. Perhaps the host could drop the hand for her.
Okay, thank you so much. All right, so we're gonna move to our last case for today. Just give us 1 second. Okay, so Misozi Ziwa from Chipata, you have the floor.
Thank you so much. I'm going to present our case history from KBS, female 43 years. She's a non-HIV patient on ART. She came to our facility on the 24th of November 2020. And when she was screened for VIA, she was found to have the results of VIA positive. And NIP was done and sent for histology. So histology results revealed that there was human papillomavirus present, dysplasia with the CIN2 lesion was incompletely excised. Admitted for hysterectomy after histopathology results, and the final decision was to repeat VIA. Apparently, hysterectomy was not done, but the doctor decided to repeat VIA. So next slide, please. So this is the picture when VIA was repeated on the 17th of August 2021. And the results were VIA positive, and there was a lesion extending into the os at somewhere 7 to 11 hours, and it was disappearing at the corner there. So the client was seen like that. So our questions are, next slide, please. What can be the best for the patient with a VIA positive result after LEAP, then how do we handle the histology results when the excision margins are not complete? Thank you so much.
Thank you so much, Ms. Ozzy. So Dr. Konga, we can go ahead and have your comments. And we'll move a bit fast through this because we are at 15:30. So just want to be respectful of your time. But
Thank
doctor,
you.
please.
Yeah. Basically, the two questions are one question in the sense that they are just different in terms of how they have been phrased. Basically, maybe the first one may be said to be maybe a recurrence or a new lesion altogether, but more likely is one question. So what we do normally is that we have to do a repeat leap in all cases which have a good ectocervix. We would do a repeat leap in these patients unless component of how we progress is the description on histopathy report, whether it's in the endocervix or ectocervix where the disease is incomplete. So if it's endocervix,
Dr. Konga, it's like your.
Sorry, I've some break.
Okay, go ahead.
It's possible to concentrate on the endocervix and do a deep leap, but in general, otherwise it's a repeat leap, and depending on the description of the histopathy report. Thank you.
Thank you, doctor. We'll take one more comment from any of our expert panel, if they have any, and then we'll move to close the meeting, because I do realize we're over time and I just want to be respectful of your busy schedules. Professor Mulindi, do you have anything to add? Okay. Dr. Kamfwa?
Hysterectomy is still indicated if at all there is nothing more to excise on the cervix. So hysterectomy would be the last component.
Okay.
Hello, good afternoon. This is Dr. Manga. Can I just come in before you close?
Yes, please.
Okay, so I've been following in the background, though I've been engaged in some clinical activities. But then I wanted to just make a point with the first case that was presented by Dr. Kamfwa. That was from Petauke. So concerning that case, I think we needed to acknowledge, as Professor Mwana Hamuntu had mentioned, on the fact that they were able to notice that this patient was in shock, and the fact that it was well managed. I think that is a thumbs up for the team in Petauke. And also the other concern I had, I think probably Professor and Dr. Kamfwa can come in, is basically the point of the linkage. I think the challenge we have in Eastern Province is we know that as a matter of fact, we have a challenge in decision making amongst our patients because they believe the parents and the guardians need to make that decision. So if we
so sorry, Abigail, can you please mute yourself?
Sorry, Abigail.
Thank
Hello.
you. Yes, Dr. Mubanga.
Yeah, sorry, I was getting bad feedback. So what I was saying is that we have a challenging case, especially
Sorry, Dr. Mubanga, it looks like we accidentally muted you. Can you please unmute yourself and come back to the stage?
Okay, can you hear me now?
Yes, very clearly. Thank you.
Okay, so my concern, the first one was a thumbs up to the team in Petauke. Then the second acknowledgement I wanted to make was in the aspect of linkages. How do we link our patients with confirmed histopathology results to UTH? Because most of them are willing to do the biopsy, but then they're not willing to go to Lusaka. So the precedence has been that they are not they're not well accommodated in Lusaka. So that came up as a gap, which we hope, and I've given feedback to Dr. Kamfwa in some of those cases, isolated cases. So they would actually prefer to remain in Chipata because it's close to home, and probably if it's possible, we can link them with chemo and radiotherapy. But the challenge we have is that we don't have any radiotherapy services being provided in Eastern Province. So that is probably my contribution, and probably Professor Mwanas and Dr. Kamfwa can come in and shed more light on those two observations. Thank you.
Thank you so much for those insights. All right. So we'll go ahead and move to close, only because we've been having a lot of great discussion, and we always welcome and we always love that. The only thing is now we're running out of time. And because we know that you are all very busy health professionals who are saving lives, we're gonna go ahead and let you all go. And we do appreciate, and we'll see you again in the next few weeks. Please be open and look out for our invitation that's gonna be coming through. And as always, we appreciate your attendance and just being available. And thank you so much for all the work you're doing on the ground. Have a lovely weekend.
Thank you. Bye.
Thank you.
Bye. Thank you for the nice presentations to all the districts and facilities.
Thank you. Keep saving lives out there. Women are needed in our communities, guys.